I'm thankful to the faculty of Fatima Memorial Medical College and especially to Dr. Saqib, Dr. Nasir and other organizers of this course. They've asked me to discuss with you a very important topic from emergency medicine point of view, and that is evaluation of a patient who comes to you with chest pain. Chest pain is a very important symptom, and about 45 to 55% of patients coming to emergency room of any general medical hospital, not to talk about a cardiology hospital, come with this symptom. And the evaluation is in two parts, which really starts from your clinic if such a patient walks into your clinic. Number one, you have to establish a correct diagnosis whether the patient is suffering from a life-threatening or potentially life-threatening condition, or is he suffering from a benign condition. And if out of those life-threatening condition, ischemic heart disease is one of the potential diagnoses or one of the differential diagnoses at the top of the list, then therapy should be started as early as possible, because in cardiology there is a saying that time is myocardium. That you don't want to send that patient for care after he has lost much of his myocardium. Then probably even good cardiologists cannot offer much to the patient. So that evaluation basically depends upon whether patient has ongoing chest pain or history of episodes of chest pain. So a patient who walks into your clinic saying that I have chest pain now, you got to tackle that patient or approach that patient in a different manner. And a patient who tells you that since last 10-12 days I am having chest pain which comes for 10-15 minutes and goes away, and at that time I'm alright, I had last such episode about 2-3 hours ago, you have to approach that patient differently. So it's the symptom of chest pain covers very wide spectrum of diseases and very wide spectrum of a single disease entity. So you have to decide whether the patient who has come to your clinic needs to go to an emergency room right now, or you can start him on some therapy and order some investigations to see whether he is suffering from a life-threatening or potentially life-threatening condition and needs to see which type of specialist care. So that, first of all, you established whether the patient is hemodynamically stable or not. It's not necessary. I know that sometimes hemodynamically unstable patient very often gets to the clinic of family physician, not realizing what they are suffering. So first thing you have to establish, and look within 4 or 5 minutes, whether the patient is hemodynamically stable or not. How is his pulse, blood pressure, is he sweating, is the pulse thready, is he short of breath, is there any diaphoresis, is the blood pressure on the lower side. And then after ruling out any acute condition, you go on to evaluate chest pain on the basis of history. And very important component of history is not only history of pain, what type of pain he has, where he or she has the pain, what are the precipitating relieving factor. You have to evaluate every chest pain in the light of risk factors that patient has. It's a very, very common example. A 35-year-old healthy male who is not diabetic, who doesn't have diabetes in the family, who is not a smoker, is otherwise healthy, with the same type of chest pain, you'll approach that patient a bit differently as compared to a 35-year-old male who is smoker and belongs to a diabetic family who has also family history of ischemic heart disease. So every patient who comes with chest pain, his chest pain has to be analyzed in the light of risk factors he has. And there are 5 hard risk factors for coronary artery disease. Number 1, family history, very important. And the art of history is to dig it out. You'll ask the patient, आपकी फैमिली में हार्ट प्रॉब्लम है? वो कहेगा नहीं जी। माँ बाप जिंदा हैं? नहीं जी, उनका तो इंतकाल हो गया। वालिद साहब कैसे फौत हुए? जी वो सुबह अचानक फौत हो गए। आज से 10 साल पहले मैं छोटा सा था या 12 साल पहले मुझे बताया गया कि वो अचानक फौत हो गए। So sudden cardiac death, sudden death, until otherwise you are 100% sure that sudden death happened due to brain hemorrhage or electrocution, should be taken as positive family history for coronary artery disease. So the history has to be taken in detail and not only what the patient tells you. So family history, smoking, hyperlipidemia, diabetes mellitus and hypertension. These are the 5 factors which you must know, that whether your patient has any one of those or more of those. After history, and we'll talk about in detail, you go to physical examination, ECG, analysis of ECG and biomarkers. Next slide. So what are the causes of chest pain? It is very important to realize, again at the level of a family physician, at where the scrutiny really starts, that any chest pain which is not ischemic chest pain can be more fatal than coronary artery disease. So causes of chest pain which are more important even than coronary artery disease, one of those is aortic dissection. And these are the patient in whom you are not supposed to give low molecular weight heparins at your clinic, heparin or low plat or clopidogrel or disprin. So just to give you a hint, what is the difference? The chest pain of coronary artery disease usually starts as a mild discomfort and comes and goes and then gradually rises. It is usually in front of the chest or in the left arm, usually in the center or left precordium, rarely on the right. The pain of aortic dissection, when it starts from the peak. The patient has severe excruciating pain from the word go. It doesn't build up. It starts, in most of the cases, it starts from the maximum intensity, is usually but not always located in interscapular region, but also comes to the front and more commonly radiates to the neck than pain of coronary artery disease, and happens usually in patients who are known hypertensive. So if a patient who comes to you with sudden onset severe chest pain, which is maximum from the start, is not waxing and waning, you should keep in mind the diagnosis of aortic dissection, the management of which is quite opposite to the management of coronary artery disease. So other causes related to cardiovascular system are pericarditis, and pain of pericarditis is dull, increases on inspiration, the type of pain we call pleuritic, and is relieved by sitting up and leaning forward, and is increased by deep inspiration. It is associated, the common catch here is, it is associated in many patients with ST wave changes on ECG. But ST changes, ST elevation in patients with pericarditis is concave upwards and is in all leads, almost all leads. Whereas ST elevation of coronary artery disease is either horizontal depression or elevation is convex upwards. Probably I have ECGs, I'll show it to you. So other causes which are as important as coronary artery disease are pulmonary embolus, in which patient will be quite hungry for air, will be very dyspneic. Pneumothorax, pneumonia, a history of fever will be there, pleuritis, and there are many other causes which you can very well most of the time establish on the history of on patient history, especially if you keep in mind the risk factor profile. But the one disease which is very difficult to differentiate sometimes is reflux esophagitis and esophageal spasm, which is often relieved by sublingual nitrates as well. Anxiety disorders, chest wall, especially herpes zoster, the pain will be in dermatomal distribution and not retrosternal. Next slide. So these are causes of pain as regarding the distribution. Retrosternal, you will have ischemic pain, epicardial, esophageal, aortic dissection, mediastinal lesions, pulmonary embolization. Epigastric pain, a very common cause of ischemic heart disease. We many a time see patients who have typical ischemic pain in epigastric region, and even consultant physicians are treating them as peptic ulcer disease. What is the difference? Postprandial status always puts a more demand and more load on myocardium. There is more blood flow to the stomach and intestine, and the heart has to work more. You will find many patients who can walk gently for 2-3 kilometers empty stomach and they will not have symptoms, and they will tell you कि डॉक्टर साहब खाना खाने के बाद पेट में दर्द होती है, and there and then the prescription will start, omeprazole, motilium, antiemetic medicine. You just ask one question कि खाना खाने के बाद दर्द बैठे बैठे होती है या चलने से होती है? If the patient says that he never gets epigastric pain after meals if he is resting and only gets it after activity, after meals, half an hour, 15 minutes, 1 hour, the pain in all probability is coming from myocardium and not from his stomach. So from basic rule, any symptom from umbilicus to lower jaw, any symptom, not only pain or discomfort, any symptom from umbilicus to lower jaw which comes on activity and settles down on rest, the diagnosis of coronary artery disease must be ruled out by all measures and means before you say that patient doesn't have coronary artery disease. Any sort of symptom, and we'll talk about the term known as angina equivalents, which are as important as angina. So the pain can start from anywhere, from umbilicus to lower jaw, and can radiate to anywhere. The most important thing, I am also again and again referring to the word pain. Most of the patients who have some chest pain or discomfort as symptom of coronary artery disease don't really describe it as pain. They describe it as discomfort, some gripping feeling, some constriction. Very few patients describe this discomfort in the chest as pain. So if a patient, while describing whatever he is describing to you, makes a fist over the chest like this is called Levine's sign, L-E-V-I-N-E-S, Levine's sign. It is quite specific for coronary artery disease. If a patient says that I get dyspneic on walking, and he can localize dyspnea, कि डॉक्टर साहब इत्थे साह रुक जा जांदा है. If dyspnea is not coming from myocardial ischemia, then in all probabilities it will not be localized. It's a diffuse feeling. Patient is short of breath. But if a patient who gets exertional dyspnea and can localize the feeling of dyspnea to some part of chest, in all probabilities that dyspnea is angina equivalent. Next slide please. So this is the approach to a patient who comes with new acute, often ongoing chest pain. First of all, you establish whether this, just for the sake of completion, first of all you establish whether the patient needs emergent treatment. You focus on history, physical examination within 5 minutes, and the patient, you may not get a cause, or there may be potential cardiac cause. We'll talk about this in next slide. And other causes are aortic dissection, pleuritic pain, pneumothorax, and musculoskeletal. Next slide, please. And now this is more relevant to our topic, new acute often ongoing chest pain of potential cardiac cause or of uncertain cause. You do the EKG. EKG may shows an acute Q wave myocardial infarction in which there will be ST elevation or changes suggestive of ischemia. Treat as unstable angina, and abnormality is not diagnostic. You are still in a fix. You have taken a good history, you have done physical examination, you have done ECG. Nothing is clear. What to do next? Consider nitroglycerine and an observation period to exclude acute coronary syndrome. You should refer the patient to the nearest hospital emergency. Consider further cardiac testing, including the test which is now available is troponin T and troponin I, and we'll talk about it in short time. Next slide. So evaluation of patient history, evaluate history and establish diagnosis, risk stratification, and we'll talk about it. Also decides next investigation. This is very important. History in patients with coronary artery disease does not only tell you what is the diagnosis, but if you take a proper history, it will tell you how to investigate the patient further. There is a young man, 45-year-old, who walks 10 steps. Earlier he could walk 2 kilometers and would get chest pain and sit, and that chest pain will go off with rest. Now he gets the same chest pain since last 1 week after walking, say 20 yards, and that chest pain is associated with shortness of breath. Both are relieved with rest. You know that this patient needs coronary angiogram. You start treating him, you put him on antiplatelet therapy. If there's no contraindication, you put him on beta blockers, you give him statins, and you ask your area cardiologist to do a coronary angiogram on this patient. You don't need to send this patient for any sort of stress investigation, ETT or thallium or stress echo. Stress he is doing daily. He is telling you what will be out of stress. There is a 75-year-old person retired from the job. He also has some bronchial asthma, peptic ulcer disease, probably other illnesses, comorbidities. Comes to you with the same history. You can give him medication, see whether he settles down or not, and then if he settles down, if his symptoms are relieved, you can ask for a stress investigation, especially thallium test, to see whether the myocardium at jeopardy is significant or not. So history, patient in detail evaluation only with history in patient with chest pain does not only give you diagnosis, but also tells you how to manage this patient further. Physical, next slide. So what is the diagnosis and evaluation in history? Quality of the pain, location, radiation, precipitating, relieving factors, very important. What I was telling you, associated symptoms. Is the chest pain associated with dyspnea? Is it associated with palpitation? Palpitation हुई, उसके साथ patient को syncope तो नहीं हो गई. A patient who gets palpitation and syncope with one episode of chest pain probably had ventricular arrhythmia with chest pain, from which he recovered spontaneously. First time lucky, second time he may not be lucky. So you should refer that patient immediately to cardiology service for further workup, and probably if he's a young man, probably early coronary angiogram. What is the frequency and what is the duration of pain? Next. So how usually patients describe it? It is a squeezing, grip-like, pressure-like, suffocating and heavy, or a discomfort but not pain. Very few patients, very few patients. Rather, patients, many a times I have gone through that embarrassment. Patients get annoyed. Patient आपको कहता है डॉक्टर साहब छाती में दबाव पड़ा है, आप थोड़ी देर बाद नोट्स लिख रहे हैं, अच्छा दर्द कब हुई थी, पहले भी दर्द हुआ, डॉक्टर साहब दर्द नहीं दबाव पड़ा. So patients get annoyed. If you again and again tell them कि भाई chest pain कहाँ हुई थी, they say it's a pressure, it is a grip like. Angina is almost never sharp or stabbing. A young man will come, boss is angry, यहाँ पे दर्द होती है, बार बार दर्द होती है. He will pinpoint the pain in inframammary region. The lady is not happy in the house, she will pinpoint the pain in the inframammary region. It's never stabbing, it's not cardiac, but does not change with position or respiration. Duration is typically minutes in duration. Very important. You again get referrals again and again. Patient को 10 सेकंड के लिए दर्द होती है. Fleeting discomfort or a dull ache lasting for hours is rarely angina. Location usually substernal. Heart, remember, is embryologically a midline organ. Its innervation is from midline. So whenever the pain from the heart comes, usually in patients other than non-diabetic, it is retrosternal. Pain above the mandible, as I told you, and below the epigastrium or localized to small area over the left esophagus wall is rarely anginal. And what are the provocation? Generally precipitated by exertion or emotional stress and commonly relieved by stress, rest. Sublingual nitrate also relieves angina usually within 30 seconds. If sublingual nitrate relieves pain after 20-25 minutes, it's unlikely to be angina. Next. So this is the usual distribution of chest pain coming from ischemic heart disease. Retrosternal, radiating to jaw and left precordium and inner side of the left arm. Very rarely it is only located to right precordium and coming to the ulnar part of the ulnar half of the right upper arm, or very rarely it is located to jaws or epigastrium or only to interscapular region. A very important part of history and physical examination, when a patient has come to you with chest pain and after initial evaluation you are sure that these episodes of chest pain are coming from ischemic heart disease, is evaluation of provoking or exacerbating factors. Is the patient running a fever? कोई इन्फेक्शन तो नहीं हो गया. And there are patients who are otherwise stable, but an acute infection with fever, tachycardia and everything will precipitate new onset angina. Not that they had angina earlier, they were much more active, and now with fever they can have angina with lesser activity, with lesser threshold. They will have new onset angina. So you have to see, when you take the history, that whether the angina in this patient is the lone pathology, lone symptom, or are there any precipitating factors which you should correct along with therapy for ischemia. Is the patient anemic? A 50-year-old lady coming with menorrhagia is a very good example. A 60-year-old gentleman coming with bleeding piles and having chest pain also. So you have to rule out anemia, hypoxemia, hyperviscosity, aortic stenosis, hypertrophic cardiomyopathy and all other things. Next slide. Next, this is important slide, very important thing. You will again and again listen to the way people talking about pain is typical for ischemic heart disease. Pain is atypical for ischemic heart disease. What is meant by this? These are very, very scientific terms and very few people know it. A clinical syndrome, typically what is angina? Characterized by deep, poorly localized chest or arm discomfort that is reproducibly associated with physical exertion or emotional stress and relieved promptly by rest or sublingual nitroglycerin. So there are three components to the definition of anginal chest pain. Number one, its location, retrosternal, spreading to left precordium, coming to the left arm. Number two is its quality, its characters. It is deep pain, it is not well localized, all we talked about. And number three is precipitating and relieving factors. It comes with activity and is relieved by rest. Any patient who fulfills all these three criteria has pain typical for coronary artery disease or ischemic heart disease. Simple, mathematics. All three symptoms: pain, location, type, relieving and precipitating factors. If all three things are fulfilled, the pain is typical for angina. If the patient fulfills two criteria, then pain is suggestive of angina or ischemic heart disease and may prove to be ischemic heart disease. For example, a patient comes to you with chest pain at rest. First episode, no relieving factor, no precipitating factor. Pain is ongoing, comes to your clinic, it's retrosternal, deep, is radiating to left arm, but since it has started for the first time at rest, you cannot say whether there were any relieving or precipitating factors. So this pain, you are quite sure that इस diabetic patient को coronary artery disease है और इसको करीबी अस्पताल जाना चाहिए. This pain is suggestive of angina because one of the conditions is not being fulfilled or suggestive of ischemic heart disease. And if only one or even no criteria is fulfilled, then it is atypical for angina. So these terms should be very well defined and should be used carefully. Now after history and physical examination, pulse, blood pressure, whether patient is hypertensive or not, any systolic, diastolic murmur, anemic, whether he has any basal Krebs associated asthma or not, there is the role of ECG. Remember one rule: an abnormal ECG in patient with chest pain has lots of value. It tells you that patient has coronary artery disease, like definite ST depression, definite ST elevation or evolving changes, और patient को pain के साथ ST depression थी, pain ख़त्म हो गई, ST depression ठीक हो गई, और biphasic T waves. But a normal ECG in patients with typical ischemic chest pain does not rule out ischemic heart disease. So an abnormal ECG in patients with ischemic heart disease has lot of value, but a normal ECG does not rule out. The diagnosis of ischemic heart disease on the basis of history is still based on the history. And then you can have pathological Q waves indicating past MI, SC segment depression and other conduction abnormalities. For example, a patient, young patient, probably this is not written in books, but our teachers have told us, any subtle abnormality in ECG should be taken very, very seriously. A patient comes to you with ongoing chest pain. ECG normal है, heart rate 45 है. Why? Patient is not hypothyroid, आपने एग्जामिन किया, बीटा ब्लॉकर्स पे नहीं है, चल के आपके क्लिनिक में आया है. Why is he is not a jogger, he is not an athlete, उसका heart rate 45 क्यों है, with ongoing chest pain. So from conduction abnormalities you should look for even any subtle abnormalities. और heart rate 90 है, चलो एंग्जाइटी हो सकती है, आपने एंग्जाइटी भी रूल कर ली. So there are many parts of the heart which are electrocardiographically silent. These include high lateral wall, posterior wall, जिनमें ischemia हो तो ECG में changes नहीं आती. Next slide. And then is the role of biomarkers. Up till 3-4 years ago, the only test which was available was CPK, CKMB, which was not very specific, will miss many patients with ischemic heart disease. Now the test which is to be done in your patient if you want to prove, if you're not sure history पे कि angina है या नहीं है, patient को ongoing chest pain के साथ, is troponin T or troponin I 6 hours after onset of chest pain. पेशेंट को प्रोलॉन्ग चेस्ट पेन हुई है 2-3 घंटे की, सुबह 9 बजे उठा है, 2-3 घंटे चेस्ट पेन होती रही है, शाम को 5 बजे आपके क्लिनिक पे आ गया है, उस वक्त ठीक है, ईसीजी में भी कोई चेंज नहीं, यू आर सस्पेक्टिंग कि उसे चेस्ट पे, स्टार्ट द थेरेपी if the patient is high risk प्रोफाइल ज़्यादा है, पेन वॉज टिपिकल एंड आस्क फॉर ईसीजी भी अब नॉर्मल है, कोई डेफिनेट चेंजेस नहीं है, आस्क फॉर ट्रोपोनिन टी अगर रिपीटेड एपिसोड्स नहीं हो रहे, 6 घंटे बाद, अगर वो भी नेगेटिव है तो 12 घंटे बाद, अगर both tests with first or repeated episodes of chest pain are negative and you are still not sure that chest pain is typical of ischemia or not, you can send the patient for exercise testing. But if one of these tests turns out to be positive, especially in a young man, then there are 2 roles of troponin T and troponin I. Number 1, they establish the diagnosis positive troponin T or positive troponin I कि patient को ischemic heart disease है, and number 2, more important thing, they identify high risk population. Again, with history, if a patient has positive troponin T or troponin I, and patient especially young person, he should go to coronary angiogram. Full stop. There is no need to do any stress test. अगर पेशेंट को चेस्ट पेन हो रही है, 60 प्लस का पेशेंट है, यू आर नॉट श्योर, ट्रोपोनिन टी ट्रोपोनिन आई भी नेगेटिव आ गया है, यू कैन स्टेबलाइज द पेशेंट ऑन मेडिकेशन एंड सेंड हिम फॉर एक्सरसाइज टॉलरेंस टेस्ट विच इज़ अदर मेथड्स फॉर रिस्क स्ट्रेटिफिकेशन. नेक्स्ट स्लाइड. सो दे स्टार्ट राइजिंग आफ्टर 6 hours and then there is no need to get them within 6 hours of onset of chest pain. After you have done all the history, physical examination, troponin T investigation, or even if only physical examination, आप troponin T अपने patient का नहीं कराना चाहते, your job as a family physician is not only to decide कि इस patient को ischemic heart disease है या नहीं है, your job is also to define whether this patient is in the low risk group or high risk group. Who are the patients who have low risk group? Stable angina. 1-2 साल से ये चल रहा है कि या 6-8 महीने से कि 1.5-2 किलोमीटर चलते हैं, पेन होती है, ठीक हो जाते हैं फिर. They don't have any features of congestive heart failure during chest pain or in the absence of chest pain. They have normal resting ECG और clinical examination पे या echocardiogram पे they have normal left ventricular function. These are the patients जिनको आप stress testing के लिए भेज सकते हैं. There is no need to be invasive as a first step. You can ask them to undergo stress thallium or dobutamine stress echo or ETT, get lipid profile done and start treating them. You are sure that they are patients of coronary artery disease. But the next step is how to treat them further. So they are if in the low risk, stable angina, absence of congestive heart failure, normal resting ECG, normal left ventricular failure, and here you can add normal troponin T. अगर prolonged chest pain हुई है और फिर भी troponin T normal है या troponin I normal है, they are low risk. Who are high risk? Unstable angina. We'll talk about it. What is unstable angina? They have congestive heart failure symptoms or signs. They get dyspnea on walking, with or without chest pain. They have third heart sound, they are tachycardic, they have basal creps, and they get better only on diuretics. They have resting ECG, changes with Q waves or STT wave, and they have on echo or clinical examination depressed left ventricular function. These are the patients who after stabilization should get early coronary angiogram if it is not contraindicated. अगर LV इतना ख़राब नहीं हो गया कि angiogram नहीं होनी चाहिए. So these are the patients who do not need to get an exercise test done or a thallium test done, these are the patients who should undergo coronary angiogram straight away. And what is unstable angina? More frequency of chest pain, more episodes. Episodes coming with less activity. पहले पेशेंट 2 किलोमीटर चल लेता था, अब आधे किलोमीटर चलने से हो रही है. More need to put sublingual nitrates. Prolonged pain, पहले 2-3 मिनट में ठीक हो जाती थी, अब 15-15 मिनट में ठीक होती है. And new associated symptoms and new area of radiation. And most important, जहाँ पे सब लोग गलती करते हैं, new onset angina. New onset angina in any patient जिसे हफ्ता 10 दिन से chest pain शुरू हुई है is unstable angina. And what is unstable angina? Unstable angina means you don't predict कि इस पेशेंट के साथ, you cannot predict कि इस पेशेंट के साथ क्या होना है. दवाइयों से ठीक हो जाएगा या 15 दिन बाद MI के साथ अस्पताल में दाखिल हो जाएगा, 2 दिन बाद MI के साथ अस्पताल में. That is unstable angina in short. So if you cannot predict, एक पेशेंट 2 साल से 3 किलोमीटर चलता है या 2 सीढ़ियाँ चढ़ता है, 2 मंजिल सीढ़ियाँ चढ़ता है, फिर चेस्ट पेन होती है, ठीक हो जाता है, you know कि यही हो रहा है, इसको अभी फौरी तौर पे कुछ होगा नहीं. In all probabilities, I'm talking as a doctor, not as a sort of Islamic belief, whatever it is. So you can, on medical grounds, you can predict कि इस पेशेंट के साथ क्या होगा, ठीक है. And that is a patient you don't need to send for early invasive investigation. Next slide, please. Next. So this is how the angina evolves. Next. If you can understand this slide, I think you can understand angina and you can treat your patient very well. If you occlude a coronary artery here, it's very important. Coronary artery occlusion at 0 minute. At about 2-3 minutes, अगर आप उसी वक्त डॉग की या उस पेशेंट की एको कर रहे हैं, तो first thing will be diastolic dysfunction. The second thing will be systolic dysfunction. The third thing will be hemodynamic abnormality. पेशेंट को टाइकार्डिया हो जाएगा, बीपी कम हो जाएगा, या अगर एलवी अच्छा है तो बीपी राइज कर जाएगा. The fourth thing will be ECG changes. And the last thing will be angina. What does this graph tell you? This graph tells you कि अगर आप यहाँ पे occlusion खोल दें, आर्टरी यहाँ पे आपने occlude की 0 मिनट पे और 18 मिनट पे खोल दी, that patient will have neither ECG changes nor chest pain. इस ग्राफ के इस सारे हिस्से को we either call silent ischemia or angina equivalence. For example, इधर आपकी systolic abnormalities आ गई हैं. अगर पेशेंट की एक बहुत मेन coronary artery occlude हो रही है, जो मायोकार्डियम, बहुत ज़्यादा मायोकार्डियम को 30-40%, 25% मायोकार्डियम को सप्लाई कर रही है, तो सिस्टोलिक एबनॉर्मेलिटी के साथ, सिस्टोलिक डिसफंक्शन, वीक पंपिंग के साथ पेशेंट को यहाँ पे डिस्निया हो जाएगा. दिस पेशेंट हु occludes his artery here and opens up his artery here, you haven't done ECG, opens up here, will not come to you with chest discomfort or pain or gripping or squeezing feeling. He will come to you with other symptoms like palpitation, अगर उसे इस सारी abnormality के दौरान एरिथमिया हो गया, like syncope, like चक्राना, अगर बहुत ज़्यादा मायोकार्डियम इन्वॉल्व हो गया, like lethargy, weakness, काम करने को दिल ही नहीं किया, दिल बैठ गया एकदम. So this is very important, and this tells you that when a coronary artery occludes, then ECG changes, if the ECG changes are to come, are the second last thing, and chest pain or chest discomfort is the last thing. So your job as a family physician is to dig out history in detail and to really know कि मेरे पास जो पेशेंट आता है कि मैं चलता हूँ तो सांस ख़राब हो जाता है, बैठता हूँ तो सांस ठीक हो जाता है, वो चेस्ट पेन के लेवल तक गया ही नहीं, उसका सांस इतना फूल गया है, he is so much dyspneic that he had to stop before he gets here. And so you have to decide कि ये मेरे पास मेरा पुराना ब्रोंकियल एस्थमा का पेशेंट ख़राब होकर दोबारा आ गया है, या ये मेरा इस्केमिक हार्ट डिजीज़ का पेशेंट है जो चेस्ट पेन नहीं बल्कि डिस्निया के साथ आ रहा है. सो द नेक्स्ट स्लाइड. सो दीज आर द सिम्टम्स विच आर कॉल्ड एंजाइना इक्विवेलेंस. एंड अगेन द रूल ऑफ द थंब इज के इफ एनी सिम्टम इन अ पेशेंट with risk factors or sometimes even without risk factor comes on activity and goes on rest, is relieved by rest, you must actively rule out. It's not definitely coronary disease. An anemic patient will get dyspnea on activity and will be fine when he sits down. But this is the thing you have to rule out on history and physical examination. So patient can get dyspnea, patient get lot of sweating, cold sweat. यदि बैठे बैठे डायबिटीज़ का पेशेंट आएगा, now a diabetic patient comes to you कि जी कल मुझे बैठे बैठे शाम को पसीना आ गया. Now your job as a family physician is कि उसे हाइपोग्लाइसीमिया हुआ है या इस्कीमिया हुआ है. If that patient बैठे बैठे पसीना आने से एक घंटा पहले उसने शाम की चाय पी है, साथ बिस्किट भी खा लिया है जो उसे नहीं खाना चाहिए था, जो आपने मना किया हुआ है, he cannot be hypoglycemic. You got to see कि इस डायबिटिक पेशेंट को डायफरेसिस एज एंजाइना इक्विवेलेंट तो नहीं हो रहा. You have to actively rule it out. Palpitation, syncope. Many patients come, chest pain नहीं होती जी, चलने से, ख़ास तौर पे लेडीज़ में चलने से दिल ज़ोर ज़ोर से धड़कना शुरू हो जाता है, मुझे बैठना पड़ता है. They sit down, they don't get to the level of chest pain. Palpitation इतनी होती है कि they sit down, they can't walk anymore. So with detailed history, physical examination, you have to see कि इस पेशेंट को एस्थमा है, एनीमिया है, क्या हो रहा है, is it ischemic heart disease. GI motility system, चलने से डकार आने लग जाते हैं, मैं बैठ जाता हूँ, डकार आता है, ठीक हो जाता हूँ. That patient will be in a false impression कि उसका हाजमा ख़राब है. But remember उसे डकार चलने से आ रहे हैं और यहाँ पे कुछ फंस गया है, गैस खारिज होती है, ठीक हो जाता है. लेकिन वो ठीक इसलिए नहीं होता गैस खारिज हो जाती है, वो ठीक इसलिए होता है कि वो बैठ गया, चलते चलते डकार आने शुरू हुए हैं या गोला सा बना है, डकार आए, ठीक हो गया. लेथार्जी एंड वीकनेस वेरी इंपॉर्टेंट, ख़ास तौर पे अ पेशेंट हु ऑलरेडी हैज़ एन एमआई हो गया, हार्ट ऑलरेडी डैमेज है, अब चलता है, वीकनेस हो जाती है, बैठता है, ठीक हो जाता है. His rest of the myocardium is also jeopardized. Next slide please. We'll talk about it detail later on. Next. So just angina treatment, A aspirin anti-anginals plus minus ACE inhibitors, beta blockers and blood pressure control, cholesterol and cigarette quitting, diet and diabetes, education and exercise. So in brief, the diagnosis of ischemic heart disease in the best hospitals of the world is dependent upon good detailed history taking and nothing else, and that must include, you cannot make a valid or a strong or a proper diagnosis without having the history of risk profile of patient. Diabetic patient जिसे रात बैठे बैठे सांस ख़राब हो गया, 15 मिनट बाद ठीक हो गया, सुबह आपके क्लिनिक में आया है, is not suffering from asthma. मोस्ट प्रॉब्ली उसे जो 15-20 मिनट के लिए सडन ऑनसेट डिस्निया हुआ है, उठ के बैठा है, खिड़की खोलिया है, लंबे लंबे सांस लिए, ठीक हो गया है, वॉज फर्स्ट एपिसोड ऑफ सीवियर एंजाइना जिससे वो लकीली खुद निकल आया. योर जॉब इज़ टू प्रिवेंट द नेक्स्ट एपिसोड फ्रॉम विच ही मे नॉट सर्वाइव. थैंक यू.